So we start recently listen to a lot of talk saying that ray tracing and the importance of the ray tracing in our examination and in our treatment. I do agree fully, and I remember when I was presenting some element related to the biometry, and I said that the future is to ray tracing because it gives the power, the total corneal power. So one day, Usama, he went to me, he said that, well, just let us see how the ray tracing is working. It need a special tool. Why we couldn't use the ray tracing when we had Scheimpflug? Because the Scheimpflug, as a technology, it can't, I think that is forward, backward? Yes. Because Scheimpflug, it can't reach the posterior corneal power. And that's why the controversy between those that they are using topo-guided or corneal wavefront, depending on the anterior corneal power or anterior corneal analysis, compared to those that they were using ocular wavefront, that it's total cornea, and they have the ability to subtract the anterior from posterior, so they calculate the posterior mathematically, and then they reach to the total corneal power. So they were one step in front of us, but that step is mathematics step. Until ray tracing technique or technology appeared to be more reliable to be connected to our laser machine. So the aim is to have the total corneal power. What we mean by total corneal power, we are estimating, we are able to estimate the high order abrasions of the anterior, the high order abrasion of the posterior, the total K, and we have the mean, and that's what we need in irregular cornea. We are not treating the anterior, we are treating total, especially in keratoconus. And that machine, that's the technology that it shows how we reach to. But why we are not using Scheimpflug for that? It can be used, but it's not reliable. So how they made the Scheimpflug reach the posterior, that depend on a special scanning with the blue light. That's what IVUS now using. But let us see the comparison between OCT. When OCT started, posterior corneal power start to be estimated and reachable. Non-mathematically, it's real corneal power posteriorly and stromal and anterior. If we add Placido disc to the OCT, we will have a good analysis for the high order abrasions of the anterior and the ability to reach the power of the posterior by OCT. But what about Scheimpflug? They enhance it and they consume that they can reach to the posterior. So in the past, we had the Cyrus. Then Cyrus Plus, they enhanced the Scheimpflug, all Scheimpflug. But when Pyramis, when we are comparing to Pyramis, which is an ocular wavefront, Pyramis have Placido disc, all of them have Placido disc, but addition to Placido disc, it has the ocular wavefront, and mathematically they are doing the calculation for the total corneal power. Comparing to the MS, it's an OCT, have the ability to reach the posterior, and with the Placido disc that have a software to analyze the high order abrasions depending on the pyramid, and that pyramid is selectively select the clinical significant high order abrasion. That's why we can, with a tissue saving, treat the irregular cornea, especially keratoconus. And if we will go to what's appear highlighted to treat and connect it to a machine, because we have eye trace, it's an ray tracing, but it's not connected to machine. We have MS39 that connected to Schwint. I don't have any financial disclosure. And we have IVUS connected to their machine. Now IVUS still using the Scheimpflug. OCT is using, unfortunately. Yeah. OCT, sorry, MS39 using the OCT. And that's the comparison. We can see here, it's highlighted. The wavefront Zernick in MS, it's detected in a good way with analysis of the high order aberrations, as I said. But in them, in the IVUS, we need to ask, and it depends on the Scheimflug analysis without selection. And the surface detail and the epithelial mapping is only in MS, not in the IVUS. Now, that's the introduction, and that's the story. Here is a non-selective, here is the total, and here the selective. So when you have the ability to select the clinically significant, which is above 0.25 diopteric equivalent, that will be in orange, and the red is 0.5 diopteric equivalent. So when we have the ability to treat clinically significant, you can save more than 10 micron or 15 micron, which is a large amount in the keratoconic. And that's what we are saying. We are treating now, this is the anterior comma, or anterior high order abrasion and high order abrasion map. And this is the posterior, and this is the total. It's an example. It's a simple example in a normal person. So here, showing how we are saving the tissue by treating the total comma and preventing that the compensation of the posterior to anterior, because when we were treating only the anterior comma, we will disturb this compensation. But when we are treating the total comma, we will keep the compensation of the posterior to anterior. And that's the important thing. It's not only saving tissue, it's to keep the compensation of the posterior to anterior. And that's the total corneal power in MPP, the main pupillary power. And that main pupillary power with its astigmatism, with its axis, is an important diagnostic tool to guide us to the site of the incision when we are doing KRAS, to the treatment of the comma, and to treatment of the astigmatism when we are treating astigmatism when we are doing the IOL toric. So, ray tracing having the highest clinical application comparing to topo-guided and ocular wavefront. And this table show all the difference. Now, why I'm presenting the STAR-X? Because STAR-X is the first presentation published that include the high order abrasions as a total, and it's different than Athens protocol by including whole cone, and the size of the trans-PRK or PRK, it was including the cone outer border, and that's the important point that different from Athens protocol. So here, it's measuring the outer border. The optical zone is different than fixed. It's variable according to the cone. Comparing to Athens protocol. And Athens protocol, sorry, this is the study. And this is the Athens protocol. Athens protocol, Canelopoulos, he was depending on fixed optical zone. It's 5.5. Thought that 5.5 can regularize the cornea, but sometimes the cone is outside that optical zone, so it will not be regularized. And the aim or the problem is that when we are treating comma, we need to apply a hyperopic myopic pattern, and the hyperopic myopic pattern exactly follow the comma. The comma is as a comma. The cone is the main treatment site that we are treating. And when we are treating the comma, we are flattening that side. The adjacent valley will be steepened, and the adjacent steepened will be flattened. That's the comma. That's the hyperopic myopic, which is first described by Canelopoulos. So the outer border of it should be included in, but in partial treatment. And if you can see the difference, the treatment difference, we can see that the treatment, but the inner side is not being treated because it will be steeped. That's the difference. That's the treatment application. And the treatment will be flattened, and the adjacent side of it will be biomechanically steeped. And that's what we call redistribution of the K, regularization of the cornea. Redistribution of the K, we mean that the steep K will be flat and the flat K will be steeped. And And that's how we are measuring the outer border of the cornea, depending on the MS39. There is a software that can measure from the central point to the outer border. When we reach to the green, that will be the half of the diameter of the optical zone. And that animation shows that the machine should have 6D in a way that can treat this platform, the myopic, hyperopic, and then we will end up with this regularized cornea. Now, why this study unique? It's unique because it's transepithelial, having 7D as a torsional eye tract system in their machine, and it includes the outer border of the cone. The optical zone is variable. And that's very simple animation that shows how the difference between using 5.5 and 7.9 but partial. The 7.9, you have 50 micron to be treated. That 50 micron should make the stroma not less than 350. This is the rule, how we are treating. But if we are using 5.5, that's right, we can treat more, but it's irregular. So the aim is to treat, definitely we are using the shunt. The aim is to treat 50 micron and not less, the stroma should not be less than 350. 100% transepithelial, 100% selective in a way that we can select the only clinically significant. Smart. What we mean by smart application is that the spots, it's in hexagonal, not in a parallel, because if it's in parallel, we need to fill the gap, and when we are filling the gap, we will create a non-smooth surface, but when it's hexagonal, we don't have gap. That's the software of the machine, how applied. So it's a mix of treating the total corneal power with the ability of the machine to reach and to save and to keep the corneal surface smooth, and to select the high order abrasions. In conclusion, the ray tracing demonstrates effective result in treating irregular cornea like keratoconus and improve corneal regularity with the safety and efficacy profile. Thank you very much for you.